case, 16-year-old boy, follow-up case of Hodgkin's disease. And in this scenario, what was happening was that this child had received cervical radiation earlier. And on reporting, what was found was that his FT4 was normal and TSH was slightly elevated. TPO was negative. There was a small nodule which was present in that perspective, and there was no treatment which was given in that regards. Now, we need to understand that when we are looking at thyroid function and a thyroid swelling, we also need to look at the background of the particular individual. And if there is a history of radiation, there is a very strong risk of having malignancy, which we need to be bothered about and concerned about in that perspective. So clearly in this case, on follow-up, this nodule progressed and there was a papillary carcinoma which developed. So we need to understand that when we have a thyroid nodule, there is a high chance of malignancy to begin with. The chances become more particularly if there are some underlying disorders, especially in the setting of radiation, which becomes relevant. All of you can go and have a look at our website, learning.growsociety.in, where there are a lot of courses available regarding pediatric endocrinology. We run a number of programs in terms of lecture series, in terms of grand rounds. Our books are there for publication, and also we have got the application which we can use. So today we're going to talk about thyroid swelling, which is quite important from both pediatric as well as pediatric endocrine perspective. So when we look at the thyroid gland, we all know that the pituitary controls the thyroid using the TSH, which is acting on the TSH receptor, which causes the thyroid growth. Now, TSH is the potent thyroid stimulating hormone. So if somebody has got a high TSH, that will stimulate the growth of thyroid, and that can ultimately lead to development of nodules and malignancies in these scenarios. So when we are treating somebody with a thyroid swelling, we don't want the TSH levels to be very high. As we discussed in the previous case, wherein we found that this child actually had a history of radiation, and that is something which caused all those problems in that perspective. Now, similarly, if there is a TSH receptor antibody, it is also going to work on the thyroid to increase the size of the thyroid gland. Now, function could be both hypothyroidism. If you have a blocking antibody or destruction of thyroid, you will have hypothyroidism. Or if it's a stimulatory antibody, you will have thyrotoxicosis. The other problem with the thyroid swelling can happen is the compression. So there could be a compression of the respiratory tract and dysphagia which may happen. Now, these are uncommon in most pediatric settings. The more common settings would be that swelling is there, but you don't have any compression because it tends to be softer in nature, and retrosternal extension is less common in pediatric age group, and these are pretty relevant from that perspective. Now, sometimes if the mediastinal part goes in, there could be an issue. Now, when we talk about goiter, it can largely be congenital or acquired. Congenital goiter could be because of a problem in thyroid hormone synthesis, in which the TSH will go up to compensate that. There could also be a problem of maternal antithyroid drugs, which can cross the placenta and they can cause large thyroid goiters, which can be present in that perspective, and also the TSH receptor antibody, which can be there. Rare causes include McCune-Albright syndrome, wherein you have got the increased action of the TSH receptor, or the GNAS defect, which is there, which causes increased thyroid. One of the major causes of a large goiter in a newborn will be the use of antithyroid drug like methimazole, which can cross the placenta, causing the thyromegaly by blocking. TSH receptor antibody can also cause neonatal graves. Very importantly, iodine exposure in the mother is something which is also known to have an impact in terms of the overall process. Older age group, again, TSH is a major factor as far as goiter development. So we have got the TSH, which is acting via the TSH receptor, in which you can have hypothyroidism like dysharmonogenesis, iodine deficiency, or the use of antithyroid drugs. These goiters are typically soft in nature. While if you have a TSH receptor stimulating antibody like causing Graves' disease or thyrotoxicosis, here you will find a lesion which is more firmish in nature. So the nature of thyroid swelling will tell you the picture. If it's soft, it's most likely a dysharmonogenesis or a quote-unquote colloid goiter. While if you have a Graves' disease, you will have a soft to firm goiter with increased vascularity resulting in bruit, which is there. There could also be infiltrative disorders like thyroiditis, infections in which you will have more firm and bosselated swelling. So the type of thyroid swelling will determine the type of clinical field will tell you which is the more likely diagnosis in that regards. Now, when you talk about thyroid nodule, that can be part of multiple scenarios. You can have somatic mutations in particular genes of thyroid growth, like TSH receptor mutation, and this thyroid swelling can typically happen in the form of adenoma. But there are other non-thyroidal cysts which can also be there. We can have lesions like a thyroglossal cyst. In the path of thyroid descent, you can have trapment which can happen. There could be a ectopic thyroid, and also there could be a malignancy which has got genetic, obviously, in that regards. Other swellings can also cause thyroid enlargements like teratoma, lymphoma, and I've even seen tuberculosis presenting just like a central neck swelling, which was found to have tuberculomas in that perspective. Now, thyroid nodules in children are common. 2% cases will have that, but if you follow them up over time, 75% of them are known to resolve over time. Malignancy risk is around 7 to 14%. So compared to adults, earlier we used to think it's much higher, but now it's pretty similar to the adult range of around 10% in that perspective. And very importantly, if you find an incidental thyroid nodule versus a nodule which is detected by a clinical examination, there's no difference in terms of malignancy outcome.
Thyroid could be TSH dependent, which includes dysharmonogenesis, iodine deficiency, Pendred syndrome, TPO, thyroglobulin defect, UOX2 defect, or due to maternal transfer of antithyroid drugs, iodine or amiodarone. It could be TSH independent, which can be present as thyrotoxicosis, like in Graves, TSH receptor mutation, or McCune albright, or like hypothyroidism in TR beta defect. It could present as a thyroid mass, which can be a DD of goiter, like hemiagenesis, thyroglossus, neoplasm, can act like a differential diagnosis of goiter. Therefore, the disorders which included in the dysharmonogenesis are Pendred syndrome. The gene involved is SLC26A4, which results in deafness, renal tubular defects, and is a mild disease. TPO defect is severe with increased thyroglobulin and perchlorate discharge. UOX2 is due to defect in gene UOX2, which is transient, and thyroglobulin defect resulting in low thyroglobulin levels, and dehalogenase defect, which has variable onset. The neonatal Graves disease occurs due to maternal transfer of antibodies, TRAB antibodies, which can result in fetal tachycardia or hydrops, but it will self-regulate by 3 to 12 weeks.
Ectopic thyroid occurs when there is a descent of thyroid gland from the foramen of cecum. That descent is arrested at some place. There is occurrence of ectopic thyroid, which has only follicular. There is no parafollicular part. Only gland is present, and it presents like a goiter. On nuclear scan, it can be detected. Can present like hypothyroidism. It moves with deglutition. Thyroglossal cyst, if during descent of thyroid gland from foramen cecum to its usual place, the gland can persist in the there. It moves with the tongue protrusion. It is usually euthyroid, and surgery is needed as it is a recurrent cause of infection and can develop into malignancy. Acquired goiter can occur due to infiltration, which include causes like thyroiditis, tuberculosis, histiocytosis, and colloid goiter. TSH dependent causes, which resulting in hypothyroidism, include iodine deficiency, dysharmonogenesis, goitrogens, and due to drugs like anti-cancer drug or tyrosine kinase inhibitor drugs, and thyrotoxicosis due to TSH-OMA and TR beta defect. TSH independent defects include Graves disease, McCune albright, and TSH receptor mutation. Autoimmune thyroiditis. Most children who are predisposed to autoimmune thyroiditis are one with APS, type 1 diabetes, or celiac. They have family history of similar illness. Family history of autoimmune thyroiditis in sibling can be present. The presentation is goiter, which is usually firm and bosselated. Diagnosis is made using TPO antibody. There is 10% risk of them developing into hypothyroidism, and treatment should be started only if TSH is more than 10 and with TSH levels between 6 to 10 if TPO is positive. Iodine deficiency, areas with deficiency of iodine present or low supplementation of iodine can result in goiter. It has usually a mild hypothyroidism course, and diagnosis at community level can be done using urine iodine level, which is less than 50 microgram per liter. Goitrogens, common goitrogens is like amiodarone, which due to increase in iodine level affects TSH action. Thionamide, which using lithium can result in goiter. And goitrins and thiocyanate, which affects MDI1, can resulting in goiter development. Thiocyanate is present in maize and cassava, and cauliflower and turnip consist of goitrins. Drugs like phenytoin, phenobarbital, tyrosine kinase inhibitors, checkpoint inhibitors acts like goitrogens. This course is self-limiting, can result in mild hypothyroidism, and treatment is to stop the causative agent. Colloid goiter occur in a setting of puberty due to increased demand, commonly seen in girls, manifests like euthyroid, and on FNAC a colloid nodule, and on ultrasound a isoechoic nodule can be seen. It is a self-limiting condition and there is no requirement of treatment. Great. Does this happen? So due to increased demand during puberty.
So what all other glands which increase during puberty because of increased demand?
Pituitary.
So pituitary enlarges, definitely this is something which will enlarge. Adrenal will also enlarge. So all these factors can be there.
Graves' disease occur due to thyroid receptor antibody, which stimulates TSH receptors, resulting in development of goiter, present with eye signs and hard to form swelling, resulting in increased hormones, both high T3 and high T4 levels, resulting in decreased TSH levels. It is severe, persistent with both thyromegaly and eye signs, and we can use antithyroid drug as a treatment or surgery can be opted. Multinodular goiter, multiple nodules present in goiter, resulting in increased levels of T4 and a decrease in TSH levels. There is a risk of malignancy and can present like subclinical thyrotoxicosis. Thyroid nodule, coming to thyroid nodule, it could be extrathyroidal, which includes teratoma or cyst. Thyroidal, which can be benign like adenoma, thyroglossal cyst, and ectopic thyroid tissue, or malignant like papillary follicular carcinoma, medullary carcinoma, or lymphoma.